Well, good morning, everybody. Welcome to Saturday of NACFC 2024. We've made it. Yay. Well, thank you for joining us in our session today. We are promoting airway clearance. Where are we now? My name is Janelle Chittister. I am a respiratory therapist at Primary Children's Hospital in Utah, Salt Lake City, Utah. And we're the pediatric center over there.
And my name is Lucy Wadsworth. I'm a clinical specialist physiotherapy at Manchester Adult Cystic Fibrosis Centre in the UK.
So here's our presentation disclaimer that we have all seen many, many times today so far, or not today, but throughout this week. Our moderator disclosure side, Lucy and I do not have any relationships to disclose related to this presentation. So our session objectives, it's in the title. We are promoting airway clearance today. That's not to discount exercise. I hope many of you had the great opportunity to see the session on Thursday, and I see Gemma here in the crowd with us. That was a fabulous session. I loved it, and I was
the entire conference.
I think so.
Until today.
Oh, we've got our own debate going on now. Yes.
King Gemma.
And so I was left from that session really feeling like both is so good and so many great points were made on both sides, so maybe both. But in this session, we are going to focus on airway clearance and guiding our patients through this new era where highly effective modulators are available and working so well for them. Raise your hand if this sounds like a familiar situation for you. So there have been so many times where I've been doing PFTs with my cute little peds patients, and they get their newest super ultimate high score. That it's the best FEV1 they've ever blown. And so then we get all finished with the PFT, and I ask, how are treatments going? How's best therapy? And they're like, oh, I haven't been doing it. Does that sound familiar? Happen to anybody? Yeah. But there are definitely reasons why we would still want to continue to do airway clearance therapy with our people with CF. So, going through our session objectives, today we will describe how patients and therapists are adapting airway techniques in the new era of modulator therapy, clinical practice, patient engagement techniques, patients' attitude toward airway clearance, and new ways of promoting airway clearance. We will also discuss the use of passive and active airway clearance techniques being used among pediatric and adult patients and evaluate clinical outcomes. And we will also describe real-world outpatient and hospital practice, evaluating the trends of people with cystic fibrosis doing less airway clearance therapies, and thoughts about the future. So, without further ado, we will start introducing our speakers, and we are so very thankful to have our speakers. They've put in a lot of great work to be here today and share with us. Thank you.
So first of all, I have to introduce Thomas Tobin, a fellow UK highly specialised physiotherapist. So please welcome to the floor, Tom.
I'm a bit heavier. All right. Hi, yeah, my name's Tom, and I'm going to be talking about kind of our experiences at the Royal Brompton in London with airway clearance and, well, what are we doing it? What are the patients kind of saying themselves, and how we're trying to kind of adjust to the new normal. So, yeah, disclaimer again. I've got no disclosures to disclose. So like I said, the objectives of this session, hopefully it will generate some discussion. I'm not pretending to have all of the answers, and I'm not saying that what we're doing is the only way or the correct way, but I think we're all learning together and kind of muddling through this new era. So it'd be good to generate some discussion and talk about kind of what other people are doing as well. and reframing the approach to adherence. So we all kind of know the historic way of doing it. 2 sessions of airway clearance a day, doing your nebs, but is there a bit more flexibility there in this new era? How we're kind of using education and different strategies to get people on board. And then I'm also going to touch on kind of sputum sampling, kind of trying to find sputum and get microbiological samples now is more tricky in the adult population, and kind of what we're doing to address that. And I've got a little bit of data from kind of induced sputums and things like that. So setting the scene. Historically, our patients had a very high treatment burden, and some people still do. But I've kind of put this kind of calendar as a bit of an illustration of what someone's day might look like. And as you can see, kind of getting up at 7, they're doing their nebs, their physio, then they're going to work. They've got to do, if they're on Caiston, Asley, they're doing another neb, antibiotic neb in the afternoon at lunchtime, having to take their equipment to work. They're coming home, they're doing some more nebs, they're doing some exercise. Then where's the time to have fun? They're busy days to try and fit all of this stuff in. They also had copious secretions. Some of our more severe disease patients would have buckets and buckets of sputum. So they had to do lots of airway clearance to clear that. So trying to fit this in was difficult. If you then kind of change the scene to ETI, I'm feeling better. I don't really have that much sputum anymore. Why am I still going to be doing all of that when actually I don't really feel a benefit? So that's kind of the feedback that we've been having. And I get it. And it's really hard to motivate someone to do something when actually day to day, if they miss a treatment, they used to know about that. Yeah, I miss my DNAs, I miss physio, I felt a bit rubbish in the evening. Now they miss a treatment, well, I felt exactly the same. So it's really hard to get kind of people on board with doing their treatments if they don't immediately feel a benefit. So yeah, this is kind of what I'm just saying there. And these are real quotes from some of our patients. It feels like a waste of time. I feel so well, I just forget to do it. And I'm sure that in your centres, you've probably heard similar statements. So yeah, it's how do we then kind of address this and still get people to do what we want to do? Because in essence, being a physio is manipulating people, isn't it? It's influencing people, getting them to do what we want them to do. So how do we do that and still look like nice guys? So just a couple of studies. There's obviously been a wealth of evidence presented at this conference about kind of the benefits and the changes that we're seeing in our patients with ETI on board. So these are just a couple of papers that I picked out, and they were looking at actually what happens in the lungs when people are on ETI. And so the first paper by Beck et al. Showed that there was significant improvement in mucus plugging, but wasn't any change, so this is on CT scans, wasn't any change in the actual underlying bronchiectasis. So that does kind of, it's a bit, we're on the fence there. So, okay, brilliant, there's less mucus, but actually they've still got bronchiectasis. So our patients kind of maybe behaving a bit more like our non-CF bronchiectatic patient cohort. And in their guidelines, they still have to do physio. So yeah, we're getting this evidence that's showing that yes, they've got less sputum. There are improvements in their actual imaging and the structural lung damage, but there is still lung damage. And obviously, I'm not going to rehash the great talk that we had, the debate, but I think that it's clear to see, and airway clearance obviously won because Gemma is from the Brompton. But yeah, it was kind of clear that we don't know, but we are still leaning towards actually we probably should be doing something. So this is just a bit of a case study. So this is a lady, and this is just to basically identify and highlight the changes that we are seeing in our population. We've got 600 patients at the Royal Brompton. And obviously ranging in severity, but we do have a cohort of quite severe disease. So this patient was 26 years old, Delta F508 homozygous, pancreatic insufficient, had diabetes, had reflux. I've put that she grew Pseudomonas and Acrobacter, but she grew everything else under the sun as well. And she was active on the transplant list. What her day looked like, what she had to do to try and stay well. So she was using non-invasive ventilation overnight, but also for her airway clearance. She was on DNAs, colomycin, tobramycin. She was on long-term oxygen therapy, ambulatory oxygen. She was having 4 to 5 admissions a year. Her exercise tolerance was severely hindered. Her family owned a pub, and she used to enjoy working kind of a few shifts just to meet people and be kind of sociable, but she was finding that harder and harder. So, and then if we look at her objective markers, so she had a FEV1 of 25% predicted. BMI was kind of on the lower side, but kind of still okay for transplant. CO2 was 6.91, so that's hence starting on the NIV. And she was on NIV with pressures of 24/6. ETI came along. FEV1 jumped to 47%. BMI kind of started to go up. She wasn't overly keen with that, but obviously now into a healthy range. And what was more interesting, her sleep study showed that her CO2 actually normalized. And also her oxygen demands kind of, just dropped off. So she was saturating well on room air and didn't actually have any exertional desaturation anymore. So it was brilliant. All these things were looking better. And so when she was saying, well, actually, I don't really want to be kind of using my NIV for clearance now. I feel great. I'm going to do all these things. But then we look at the scans. So this was before. So not a great scan. Obviously, lots of damage and some areas. I don't know if I can. There is. Some areas of kind of mucus plugging as well, kind of here, widespread, lots of changes. And then after ETI, it does look better. I'll give you that. There obviously a reduction in mucus plugging, but still that's not a normal CT scan. So that I'm just using this to highlight that maybe our FEV1 will go up and people will feel better, but actually when we're looking at scans, there is still lung damage there. So I think that there is still a role for airway clearance because those bronchiectatic airways are really susceptible to retaining mucus. We should be doing something about it. So that kind of leads me on to how are we trying to get people to do their airway clearance? So imaging is that scan that I just put up there. I think that would motivate me to do airway clearance. So we're using scans. We're in clinics, if we're speaking to patients that have decided to stop their airway clearance, we're wheeling in a computer, or if there's a computer in the room, we're bringing up their scan and using that as a teaching aid. What's this? Oh, this is sputum. This is damaged airways. It does look a lot better. So I'm not trying to be really negative with our patients, but it's just to highlight that this is what we're trying to achieve by what we're doing. Also describing and teaching the actual physiology behind airway clearance. I think that I work in an adult center. Adults make their own decisions. And if they're anything like me and like yourselves, I'm sure that you want to have all of the information available to you when you make a decision. So actually me just saying to them, no, you need to do alternate drainage because I told you so. If I can tell them why, how it works, what we're trying to achieve, obviously we have to target it at kind of educational levels. I might not be going kind of deep into physiological principles with some patients, and maybe with some patients I will be, but we tailor it to the patient. It's individualized, and we can talk about how it works. And if you know how it works, I think people are more likely to do it. If we're taking that authoritative status where we're just, well, I'm the physio, so you do what I say, it doesn't work. We know that. So let's use kind of all of that knowledge that we've got. Why don't we impart that on our patients so that they know why we're doing what we're doing? It's also kind of trying to highlight the small airways as well. Lots of our patients don't produce mucus but have sputum, and it's in the smaller airways. So they're almost presenting more like a pediatric patient of kind of times gone by. So kind of explaining that to patients, yeah, you might not bring something up every time you do your physio, but those smaller airways, I've shown you a scan, I've explained how what we're doing is going to work. They're what we're trying to target, and we might not get something up every time, but even going through the process of these airway clearance, the physiology behind it, we're moving it downstream towards the mouth. So you may well be bending over to do up your shoelace and, oh, there's something there. So we are still achieving something by doing airway clearance, even if we're not getting kind of the copious amounts of sputum that we used to see. And yeah, again, just highlighting those benefits. This is going to keep you better for longer. This is going to remove the need for IV antibiotics, remove the need to come into hospital for an extended stay. Kind of trying to give these benefits to patients. Again, we're trying to just sell it. Like, this is why we want you to do what we're doing. What we're also finding as well that is patients aren't necessarily picking up on exacerbations as early as they once did. We all know kind of the story where people will be like, I feel terrible, I'm coughing up loads, it's dark, it's green. Okay, you need to come in. Now it's like, oh, I don't know really. I don't feel great. I'm a bit tired. Yeah, still not bringing up much, but yeah, maybe a little bit more. So what we're trying to do is reframing airway clearance as that early detection, that assessment. So we use a lot of autogenic drainage at the Brompton, and more so in the UK, I think, than the US. But I think it's a great technique in terms of this new era with ETI. It goes through all of the airway kind of different segments, and we're assessing. We're doing that assessment breath, and if we're feeling and hearing mucus, then I say to patients, well, you need to do a bit more. If it's completely dry and clear and they hear nothing, they don't feel anything, cool, physio's done. That took you 5 minutes. That wasn't too bad, so we can kind of be a bit flexible in those regards. So I think that really works for a lot of our patients, and they can see that we're compromising as well. So it is a compromise, and we're trying to make it work for patients. Just a few slides on motivational interviewing. So obviously this is a technique that can be quite beneficial in framing these discussions. And it's just about adopting this non-judgmental stance, and it's trying to get patients to come to their own decisions. So again, we're trying to avoid the prescriptive, you need to do this stance, and more so it be a joint venture. So why are we doing what we're doing? What are their goals? And trying to say, right, so is your behavior, your actions, what you're doing now, is that leading to where you want to be in 10 years? And that can really have a powerful effect on people as well. So you might not notice a difference now, but I think Polly in 5 years' time will thank Polly today for doing a bit more DNAs and a bit more airway clearance. And we can kind of frame it in that regard. And I think that's quite powerful. And I'm sure everyone, I'm not a psychologist, so I won't pretend to know the be-all and end-all of motivational interviewing. But these are the sorts of things, so ORs, hence the OR. Everyone was taking the mickey out of me for putting that on my slide. But yeah, open-ended questions. So we're not trying to get yes and no answers. We're trying to get people to expand, to kind of get across what they really think and what they want from a physio session. And affirmations, yeah, perfect. Yeah, no, okay, you're doing great. Oh, you're doing loads of exercise. Excellent. Not really physio, though. So we can kind of go down that route. Reflective listening, showing that we care and we're not just there with our cookie cutter. Well, no, you've got CF, so you have to do X, Y, and Z. We're listening. We're okay. What's your life look like? What does your day look? Oh, you've got 2 kids. You're knackered. Okay, right. We can try and work around that. And then summarising at the end. Okay, so this is what we've touched on. You want to be well in 10 years' time to see your kids graduate. We've shown you scan, you've got a bit of mucus there. So how do we get from here to 10 years' time? Well, maybe there's a couple of these things that I'm saying might be of benefit adding into your daily schedule. And then just I'm curious of time, so we'll just move quickly on to just some sputum sampling. So this is just some really entry-level data that we picked up at the Brompton. Obviously, I'm sure that everyone else is noticing that we're doing more induced sputums. It's behaving a bit more like a pediatric cohort where there isn't any sputum. We need to get a sample. How do we do that? So we're doing a lot more induced sputums at the Bromptons, actually an 8-fold increase from 2018 to 2023. And to be honest, when I first started in CF, I don't think I did an induced sputum for my first 4 years. So yeah, it is something that we're doing a lot more. And I think that it is likely to continue. We're going to see lots of people that aren't productive, and then our doctors are saying, well, do they need to still be on their nebulized antibiotics? I don't know. We don't know what's going on down there. So we do need these samples. And historically, it used to just be for NTM, I'd say, that people would be desperate for a sample, but nowadays it's a lot more for Pseudomonas. And it's for making actual changes to people's routines. Are we stopping nebulized antibiotics? Are we continuing them? So yeah, this is just, again, just some of the reasons for, and a lot of them now is no samples, 23%, so almost a quarter is because we haven't had a sample in the last 12 months. Query Pseudomonas, so again, another quarter. Do they have Pseudomonas? Should they still be doing what they're doing? So yeah, so these were kind of the referrals we received. So 43, and how many we completed, success and unsuccessful. So 86% successful, slightly lower than the CF split paper, which is disappointing. But yeah, we are successful in the majority of cases. It's a bit skewed as well because there's 4 that were not successful. That was one patient was twice. So yeah, that's cheating. She just doesn't produce sputum at all. And does it affect patient care? Well, yeah, it does. So in 5 patients that we got a sample from, we stopped nebulized therapy. So we stopped anti-pseudomonals. But then conversely, 5 is the same number, we actually started therapy again. So it was like, you've stopped it, but you're still growing it. So it was actually making a big difference to patient care. So that's why I think it's here to stay. We'll continue to be doing these. So to summarize, compromise. It's not a one-size-fits-all, and we know that, individualizing airway clearance, but it's also individualizing the decision to do airway clearance now, I think. And we've got all of these different tools in our arsenal, all of our kind of knowledge and experience. We shouldn't keep that to ourselves. We should be sharing that with the patient, and then they can make informed decisions. Because at the end of the day, they're adults, and we've seen it, they're voting with their feet, but we can influence that vote with good quality information. And it has to be specific to that patient. Not everyone's going to present the same. And maybe there is the idea that we do reduce frequency of airway clearance. I kind of quickly alluded to autogenic drainage and using that as an assessment technique. And I'd say we're doing that quite a lot. So do AD, you hear some crackles, do more physio. It's clear, it's dry, you're not hearing anything. Okay, you can stop for today. Do it again tomorrow. And FETs post-exercise, obviously, hot topic. And yeah, I think exercise, lots of our patients are feeling better. They enjoy exercise. They want to do it. Can that be airway clearance? And I'd need another 2 hours to keep going on to that. But I think that it is important that, okay, let's compromise. I need you to do some huffs. I need you to do a couple of cycles of AD after you've exercised. And maybe that's okay, but we still don't really know. And prioritizing physical activity and exercise intensity, because we've all had the patients, so yeah, you doing any exercise? Well, I'm active with my kids. What does that look like? Fair enough, for some people that might be if you've got a runner on your hands and you're trying to chase them, but for some people that's watching them run and staying in one spot. That's not physical activity. You might feel tired at the end of the day because it's hard work, but you're not really being physically active. So again, it's that education. This is what we want to achieve from exercise, and this is why we want you to do it. Standing there at the park with a coffee isn't although your kids are being active, that's not you being active. So yeah, it's kind of it's reframing that a little bit as well. So yeah, thank you. That's my speech.
Thank you so much, Tom. That was fabulous. We have a couple of questions coming through virtually. The first question, what about the children on ETI from 2 years old? Do we still need to teach them about airway clearance therapies?
Whoa. So I did say I'm an adult physio. So yeah, I think that it's important that people have all of these kind of different tools in their toolkit. And we know that children pick up things quicker and easier if it's kind of drummed into them a bit when they're younger. So I don't know. I don't want to be speaking for my pediatric colleagues, but I think that an adult coming or a teenager coming into my adult service, if they have no experience of airway clearance, I think that that's going to be a much harder sell for me to try and get them to do some. So I think that there is still a role for airway clearance. Obviously, as we don't have the data, do we? But if actually that patient who started ETI at 2 years old, they're now 10, we've scanned an LCI, we've done a CT scan, there isn't any bronchiectasis, there isn't any mucus. I don't know, would I do airway clearance if I had normal lungs? Maybe not. So yeah, I don't know is the cop-out answer.
Danielle?
Hi. Oh, this is on. Good. No, that was a wonderful talk. I love how you try to incorporate the patient's perspective and everything and personalized approach. No, I was just going to say from a pediatric pulmonologist point of view.
You take it. Yeah.
No, I was like, you guys know more, like a lot more than I do about how I love like getting people to do stuff. That's awesome. But I would say that like having just recently had the experience, like teenagers, just because they're on ETI, they still can grow pseudomonas. They still have exacerbations. And then if they don't have those tools and they don't know how to use them, it's really a problem. So I agree with you that we need to still teach them and have them ready because they're going to have exacerbations and they need to be able to deal with everything going on. So I agree.
Yeah, thank you.
Tom, I've got a question. You were your CT scans that you were using to demonstrate patients still have sputum on there. Are they just routine CT scans? And how often are you repeating them afterwards to show the outcome of still continuing doing airway clearance?
Yeah, so at the moment they're routine. I don't have the clout to be requesting CT scans, but maybe if we can show that, then that might be an area of research. But if we can show that us using CT scans is influencing behaviour and maybe making people more adherent, reducing exacerbation. If we can show some data, then maybe we've got a bit more of a case to use, for CT scans specifically for those discussions. But they're routine. We tend to scan people. For people that have got more severe disease, it'll be yearly. Kind of people that are more stable, then maybe they won't have had a scan for 4 or 5 years. And then that might be a conversation with the consultant that, okay, look, we don't have any imaging and I'm trying to influence this person to do what I want them to do. I need a bit more kind of information behind me. Could we do a scan and go from there? So yeah, routine scans, and majority of people that we're having these conversations with will probably have had a scan within the last kind of 18 months.
And are patients surprised about what they actually see?
Yeah.
And especially because probably they're not symptomatic of that as well.
Yeah, for sure. Yeah, you kind of that's the biggest battle is people feel well, they're not clearing sputum, they've got nothing, and they'll do lung function or they'll do a huff, and it does sound dry, so fair play. They are clearer, but then you show them and they go, oh my god, I didn't realise that was down there. Yeah, and it really does aid with that conversation about kind of restarting things that they don't really want to do.
Well, that's a great segue to the next online question. Are you aware of a pre-post ETI CT scan study, maybe something that shows improved imaging due to increased airway clearance? And what do you think the timeline is on seeing CT improvement?
I don't know is the honest answer. it's a really good question, and I think that would be an interesting study. I went to a talk about kind of different imaging modalities and kind of the MRI, using that, and I think we used that a bit more in the US. It was really interesting where it showed from ETI initiation, lung function increased and then stabilized, and stabilized for 3 years. But then when they looked at MRI imaging, the inhomogeneity of their ventilation actually started to deteriorate again and get worse at the 2-year interval, but lung function was stable. So I think that there's going to be lots of research in this area. In terms of how long the airway clip, I don't know, and I don't think that we're ever really going to know. We know that our outcome measures aren't particularly great at trying to measure change with physio, and that's why we all say that there's no best form of physio. So I don't know if we'll ever get that answer, how long it takes to make changes, but yeah, I think that we've still got the evidence behind us to say there's stuff there that's not normal. We know that this works. Shall we do some?
Tom, your final question. What are some of your best motivational tips or manipulation tricks for patients?
Oh, wow. Yeah, it's good. It's because I'm hilarious.
There's you?
Yeah. If you have to say it yourself, it probably isn't true. But no, I think it's all about it's being personable, isn't it? You can be the best knowledgeable physio in the world, but if you can't talk to someone, it doesn't really work, and the career is probably not for you. So I think it's all about your those kind of untangibles, those kind of little jokes, the little ways you talk to people. I think that is the most important thing. But obviously having a sound knowledge of what you're asking to do stuff, that does help as well. So yeah, don't just be funny, be a bit knowledgeable as well.
Thank you, Tom.
Yes.
Can I ask? Yeah. Can I ask one more question? So this is more of a technique question. So my name's Tom, also from Ventura, California.
Congratulations.
So I know you mentioned being a little disappointed with your sputum induction numbers, but I'm telling you, I'm not getting 85%. And we struggle with that between samples we don't obtain at all and what lab rejects. We got a very tough lab, people.
Yeah.
We're doing the 10% saline up to 30 minutes with a PET valve in line.
Oh, wow.
So are you doing anything
We're
more
not
than,
going, yeah, we're
more
not
than
going
that would help me maybe increase my numbers?
Yeah, no, it sounds like you're going a bit more extreme than we are. We're doing 7%, but we use an ultrasonic nebulizer. So we're trying to get the particles a bit smaller, hopefully getting a bit more better deposition. But we do 3 lots of 5 minutes is our max. So 15 minutes. We will incorporate airway clearance, and that might be PEP, that might be autogenic drainage. I've had people doing a bit of exercise as well. Like we try kind of everything that we can, but yeah, I think that the delivery of the hypertonic saline is beneficial because we have done it with just nebulized with an e-flow or with an air compressor, and actually the ultrasonic neb, although they're becoming a bit redundant and kind of they're dying off, and we're struggling to get parts for them, but they do make a real difference with, and patients will say it. They say, "Oh, that's strong," and it goes a bit further in, and I think that may be the key to why we get a bit more sputum. And I think it's also in the education as well to patients about what is a sputum sample. Historically, they haven't struggled, so they would fill up a pot, and then actually we get our lab coming back to us and being like, "Do you have to send so much? Like, we don't need that much. Like, we're having to cut it up now and all the rest of it." Whereas actually we only need kind of the tip of a needle, like a pinprick. That's all we need of sputum. So our patients who are non-productive, I'll go, "Well, no, I do bring up a little bit." And then so actually we can reduce our numbers of induced sputums because actually our patients are productive. They just don't necessarily know that that's enough for a sample because they're so used to filling up a pot and giving the whole lot to us. So I think that's useful. And we've also kind of been looking at, one of our colleagues in the pediatric department is looking at kind of measuring organisms in saliva. So even just if someone spits in a pot, we might get something from there as well. So our lab will test kind of whatever we send. So I think that probably helps as well.
Yeah, okay. Thank you.
No problem. All right. Thank you.
And while we're swapping over, there are a few seats at the front. If anyone does want a seat, come down now. Okay, so next up we have Catherine Villagomez. She is a program coordinator and registered respiratory therapist from the Adult Cystic Fibrosis Center at Central Texas. She is going to speak into us today on passive and active airway clearance.
Okay, perfect. Hi, good morning. Oh, well, I don't think that's going to go down any further. So, I am less funny than Tom, and hopefully just as knowledgeable, but we shall see. So today I will be discussing active versus passive airway clearance. It's not going to be as great as that debate that was on the other day, but we'll see. So, our very important disclaimer, I do not have any relationships to disclose. So just a quick overview of my little presentation. I'm going to do a quick history of CF, very, very quick. And then I'll talk about the airway clearance options, some inpatient stays that we follow, and then we'll talk about the active versus passive project that I've been working on. So diving right into history. We all love a little history lesson, right? So back in 1938, American pathologist Dr. Dorothy Anderson coined the term cystic fibrosis. It was actually in the pancreas. She was noticing doing autopsies on children that there were scars and cysts on the pancreas and not the lungs, hence it's a childhood disease. They just weren't living long enough for them to find those scars and cysts on lungs or to develop them. Moving on to 1948, Dr. Paul, I'm not going to pronounce the last name because I will mess it up. He cared for infants with dehydration caused by salt and water loss during a New York heat wave. This was actually a really important discovery because it would then lead to sweat testing, knowing that patients with or people with CF had increased salt concentrations. Therefore, in 1953, the sweat electrolyte defect was discovered. And 54, Leroy Matthews established a comprehensive program with 3 pillars. They included nutritional depletion, relief of airway obstruction, and then inhaled or just antibiotic therapies. Shortly after that, centers were then established to treat people with CF. Some of the initial treatments in the 60s and 70s were mist tents, postural drainage, and inhaled antibiotics. I'm sure everybody's familiar with mist tents. They helped humidify airways to thin the secretions. However, infection control was an issue. They were used up until around the 80s, maybe even a little after, depending on hospitals. Postural drainage was a really good airway clearance option. It was created by Barbara Weber from Royal Brompton. And then inhaled use of antibiotics were initially used by Professor Hudson. Rolling into the 80s, Paul Quinton identified the defect in chloride transport. And then in 89, Dr. Lapchi with a team from Canada discovered the CFTR gene. From then, it's just been all kinds of discoveries coming. So over the next 30 years, CF geneticists have found over 2,000 different variants of the gene. So more current times, we all know that Vertex and the U.S. Foundation have partnered together to explore drug options to fix the CF protein cells. Royal Brompton at one point was led by a team, Professor Eric Alton to help develop a gene therapy program. There's ongoing research with gene editing. There's mechanical therapies to assist in airway clearance. And then, of course, improved drug therapies to assist moving that mucus. So what are airway clearance options? There are many. Active ones that I will discuss are huff cough. Active for me means like patients will use their respiratory muscles and use energy to move mucus and expectorate. So we have huff cough, autogenic drainage, active cyclic breathing, positive expiratory pressure, oscillatory positive expiratory pressure, and of course the exercise. Passive for me is where patients passively get that airway clearance, so they're not having to work so hard to move the mucus, but they should still work hard to move the mucus. So there's chest physical therapy, postural drainage and percussion, the high frequency oscillatory ventilation, acoustics, and then the oscillation and lung expansion therapy. I will quickly go over basically kind of going back to the basics over each one of these. Hopefully there's some new therapists here that'll learn something from me. So huff cough, if we all remember back in high school, we had to take that one class called physics. It is a thing. We may have learned something for it. So huff coughing, it is about air movement. To me, it's a fundamental airway clearance technique. I teach all of my patients how to do it, remind them how to do it. Although I'm an adult side, usually they come to me kind of knowing it. But I also teach my friends and family how to huff cough, because whenever they're not feeling great, I'm like, you should huff cough. That would help you move some of that stuff. So if you remember the car, I'm sure somebody knows the name for it. You pull it back, right? You like prime it and then you hold it because you're like, yes, this is going to be great. And then you let it go and it just zooms. That's how I think of huff coughing. You want to slowly take that inhalation in. You want to hold it. That allows that air to get behind the mucus, and then you're going to exhale. So then you're going to let that car go, right? Hopefully that'll get some of the air from the smaller airways moving or the mucus from the smaller airways moving into the middle airways and then out to the large airways so you can expectorate. So yeah, for me, that's a huff cough. It's fairly simple. It's very fundamental, and it kind of goes into any other active airway clearance or passive airway clearance that we should be doing. Autogenic drainage. There's actually 3 stages to autogenic drainage, and for somebody that, like you guys up here, you guys are more familiar with autogenic drainage than I am, so please correct me if I'm wrong. Autogenic drainage has 3 stages. There's an unstick stage, so that's the small airways. There's a collect stage, so that's the middle airways, and then there's an evacuate stage, so that's the larger airways. Initially, you're going to start just breathing normal, a relaxed breathing. You're going to take a deep breath in. I'm assuming this is going to be the what is that breath that you called it? Yes, the assessment breath. So seeing how much mucus may or may not be in there. So take that big deep breath. You're going to exhale fully, and then you're going to start with those small airways. So you're having the patients take a few small breaths through the nose, holding it, and then exhaling. Moving on to that is the middle airways. So moving the mucus from the small to the middle. Going back to just the normal relaxed breathing, always holding the breath because that always allows that mucus to get, the air to get behind the mucus. And then you're going to gently exhale. So medium to large, right? Repeat a few times and then back to the relaxed breathing. And then there's the evacuation. So that's when you're having the patients take those big deep breaths. Always try to remind them, don't cough unless you're done with like a couple of the big deep breaths, just so it kind of collects and then they can cough the most out. Each phase should take about 2 to 3 minutes. All 3 phases will be 6 to 9 minutes. Repeat the cycles for around 20, if possible, if they have anything in there. Active cyclic breathing, I'm not going to lie, I'm still kind of confused about this one, but it's just breathing exercise, right? So gentle breathing, breathe through your nose. You can, some patients will have like their hand on their chest, and so they can kind of feel that they're breathing and like how deep they're breathing. Pursed lip technique is really important because it does create a back pressure in the airway, so it allows that mucus to hopefully move and mobilize. So that's breathing control. You can repeat that for 6 breaths. Chest expansion, that's those deeper breaths. All right, so you can kind of think of it like the larger airways. The deeper breaths that you take, the more exhalation or forceful exhalation that you're going to do. So again, if you're working on the smaller airways, don't exhale as forcefully because you want to kind of collect it and then forcefully exhale it. And then there's that huff coughing again. So for the forced expiratory technique. Moving on to PEP, the positive exit pressure, or the OPEP, the oscillatory positive expiratory pressure. PEP can be used with a mask or a handheld device. I would always confuse these with flutter, the flutter device, that's actually the oscillating PEP. So PEP is more like PEEP in my brain. You can use a mask or a handheld device. You're basically going to inhale, right? So you want it to inhale freely. But when you breathe out, you do want the patient breathing against some type of resistance. So I believe MoPEP was a thing where you would have them, put their hand to their mouth, and you can exhale against pressure, again, causing that PEEP, that back pressure, right, to stent open those airways. You can have them do that for 10 to 20 minutes, depending on how much sputum they have. The oscillating PEP, there are handheld devices to that. Again, freely flow inhale, but then when you exhale, they're going to exhale against resistance and an oscillation, depending on the device. Kind of depends on what kind of mechanism they use to blow against. Exercise, that very important word, exercise. So exercise, we all know, is very universal, right? Like there's so much that you gain from exercise. It does help strengthen the respiratory muscles and move that mucus out of the lungs. It also strengthens the heart. It improves mood and general well-being. It improves appetite, helps control blood sugar, and ultimately maintains lung function. Standard exercise recommendations are reaching a specific target heart rate, 60 to 80%, for 150 minutes a week. Chest physical therapy, or CPT, is just used to drain the lungs. You will percuss or vibrate, taking the deep breathing, and then huffing. Again, there's that huffing and coughing. You can use equipment like drainage tables, electrical or non-electrical palm percussors, and vibrators. In combination with postural drainage, it turns to PDNP, so postural drainage and percussion. So postural drainage uses gravity to move that mucus. The idea is to have each position in a certain position so that it does drain that mucus downward. Acoustics. I don't have much information on acoustics. I don't think it's too widely used, but it is a thing. So it applies sound waves over a wide range of frequencies, hitting various parts of the lungs to move that mucus. And you have to have mechanical devices for this. High frequency oscillatory ventilation, or VEST. So this is more passive. It's made up of the two pieces. So there's an air pulse generator and then the inflatable vest. The generator sends that air through the hoses and then causes the vest to inflate and deflate rapidly. This creates that pressure on the truss, similar to the clapping. The vibrations help that mucus detach from the walls and into the large airways to cough out. OLE, or the oscillation and lung expansion, it's kind of a newer one. It has 3 different therapies in it. So it's a positive expiratory pressure, it's high frequency oscillations, and it's nebulized therapy. So it's a nice all-in-one type of passive airway clearance if patients can tolerate it. So the PEP, the positive expiratory, creates that back pressure, again, moving that mucus. I've said it so many times, right? But it does move that mucus and hopefully gets it into an area that you can expectorate. The oscillatory thins the secretions and, again, mobilizes the mucus. And then the nebulized aerosol, in combination with it all, additionally thins that mucus. Moving right along, this is actually a mural that one of our patients did. I had to throw it in there, right? So hospitalizations in Central Texas. This is just a quick couple of slides that our protocol is in Central Texas, both on the adult side and the PD side. They kind of follow the same things. So of course we increase our bronchodilators and airway clearance treatments up to 4 times a day. For sure, on the adult side, we try to use that OLE device if the patient's tolerating it, especially if they're having any kind of procedures like PIC placements or port placements. They may not tolerate the vest during their stay. If they don't tolerate, or if they put up enough fight, we will move over to a vest. We have wrap vest in ours unless the patient brings theirs from home. And then we do have physical therapy at either hospital, and they try to see the patients 3 to 5 times a week during their stay. So for the OLE inpatient protocol, we give 10-minute treatments. They're 2.5-minute cycles each of that PEP and then of the oscillations. During that whole 10 minutes, we do give either albuterol or sodium chloride, just kind of depending on what time of the day it is. The morning and the evenings are the sodium chloride, so we try to give that in the mornings and the evenings, and then the 2 middled ones in the middle of the day, they're probably going to be the albuterol. As I stated earlier, physical therapy does try to see our patients 2 to 3 times a week, 30 to 45-minute sessions, depending on what's going on. They work on home exercise programs that include walking, maybe a review of the exercises that they're doing or given to the patient. For the adult side, we actually have a dedicated CF gym. You can see our little picture here. Our gym has a treadmill, some bikes, some weights, probably a few more things that I don't know about. But the physical therapists are great at it. And then, of course, we take infection control precautions. So making sure that no more than one patient is in that gym at a time, you clean it, wait the appropriate amount of time before taking another one down. So which one's better, active or passive? We still don't know. For this study that myself and the PD Center are working on, the study is aimed to see if any of the patients' FEV1 were affected by more than 10%, depending on their airway clearance choice. Some of the inclusion criteria, we wanted patients that were 10 years and older. They must have had a change in their airway clearance at some point. And then they must be performing their airway clearance more than 50% of the time, so like once a day. Some of the considerations, we looked to see if they were on or off the modulators, but we didn't let that affect our values or our results. And then for us, exercise was defined as having an increased heart rate for 20 minutes or more per day. Some of the tracking points where we collected pre-FEV1 data, that's the absolute values and the percent predicted values. We collected post-FEV1 data, again, absolute values and percent predicted values. Their pre and post airway clearance choice, the date around the date that they changed their choice, and if they happen to be on a modulator. Preliminary data is showing out of the 86 patients, 74 patients used passive initially as their pre-airway clearance option. Most of them are on modulators, therefore they are feeling much better, right? So they have changed to a different, so only 3 patients on the post side use passive as their primary form of airway clearance. Just kind of a breakdown of it, 33 went from active to both. So some type of active airway clearance, more than likely some exercise, and then both, so they probably are still using their vest. And then 37 went from passive to active. I apologize if I said that incorrectly. So what did we see in FEV1 changes? Not a crazy whole lot difference. The pre-absolute value went from 269 to a post value of 297 liters. I wanted to point out the FEV1 absolute value just because all of the changes in GLI and spirometry predicted, so I didn't want it to skew the percent predicted results. So the FEV1 pre-predicted was 87% and it went to 91%. So in conclusion, which one is better? We still don't know, right? Some type of airway clearance is great, and we want to focus on airway clearance. We want our patients to continue to use some type of airway clearance. Always encourage them to do it, even when they don't feel great. I know my counterpart has a great little analogy that she uses for brushing teeth. Like, you don't know you have a cavity until you have a cavity at the dentist's office, right? So you don't want patients to be at that point where they are sick and they have to come in. So even if it's just a little huff cough, right? Huff cough in the morning, huff cough at night, huff cough in the shower, some type of airway clearance. So while our FEV1 did not increase significantly, there is data to suggest that using active or both, active and passive, can increase that FEV1. So we should encourage our patients to continue to use some type of airway clearance. These are my little references and any questions. Thank you.
Kathy, what's your preferred airway clearance? Do you prefer passive or active?
I prefer active.
And why?
Why? I feel like it moves mucus better.
And do you have more success rate with active clearance than over passive?
I don't, no. No, honestly, I feel like a lot of patients on the adult side, because I'm adult respiratory therapist, I feel like most of them have moved to a form of exercise, which I totally encourage, again, not just for airway clearance, for many other reasons. Yeah, so I try to promote exercise as much as possible.
Brenda?
Thank you. That was a very nice look through history.
Yes.
I guess I'd like to agree with you about active, because if we think about other diseases like diabetes and asthma, patients learn to look after themselves, to take the correct medication, and they live as normal a life as possible. And by doing active, independent airway clearance and exercise, one then also leads a much more normal life. Whereas if you have to have somebody come and percuss you or somebody come and do something with you, it's making you into keeping you as a patient, not as a normal, healthy person who happens to have CF and who can actually manage it themselves. So that would be
love
my
that.
plug there.
I love that.
That positive, normal life. And I guess the other thing is some of the passive ones do have side effects like head down tip and postural and reflux and headaches and sinus pain and all the rest of it, and which would then decrease your amount of adherence to those techniques as well.
Yes.
So, yeah, I agree with
Thank you.
Active, way to go. Thank you.
Thank you.
Okay, we have an online question. How many patients in the study cohort were not on modulators, and what was their initial airway clearance therapy choice?
That I would have to look at the data. I believe out of the, let me see, was it 86 patients, 12 were not on modulators. And I can break it down, so if you want to email me that question again, I can look at my data later on and respond to you, but I don't have that in my head. Sorry.
Yeah.
Thank you so much, Kathy. I loved your review of all the airway clearance.
Thank you.
I just wondered also when, what time period this was performed, if it was, because I just wondered if you had seen a decrease, like many of us, in your hospitalizations, and if like you're concentrating on the home environment too, like if people are also, changing permanently and not only in the hospital.
So we started collecting data. I think the earliest FEV1 that I remember seeing was 2018, so kind of around the time modulators came out. And then we are still collecting data right now. We're hoping for this to be a final project for next year, to have all the concrete data. But we keeping up with all the changes, basically, and then encouraging our patients, because they do go through times where they don't do airway clearance, and they're like, oh, maybe I should continue to do it. We're also keeping up with the modulators, because, as we know, it's not for everybody, but also not everybody tolerates it. So we have little notes aside, too, for those patients.
Kathy, in this study, you were looking for a 10% change in the FEV1. What was the rationale for that?
No rationale, I don't think. You just pick a number, right? Actually, for the rationale, so, whenever you're doing asthma assessments, you're looking for a significant change in FEV1. So we kind of wanted to go with an asthma assessment almost. I believe it's maybe 12%, but I could be wrong because it's been a minute. So we're trying to look at that type of assessment. Yeah.
Gemma?
Thank you. That was a great run through of all the techniques. Just following on from that question, do you have any other kind of secondary outcomes? Because obviously we know FEV1 doesn't really change these days.
Right.
So a 10% would be a whopping change to find. And so I just wondered if you had like imaging or anything behind you to have a look at as well.
I don't. But again, Cheyenne and I are still working on it, and Melissa, we're still kind of working on things. So I think because it's a retrospective study, I think we could probably go back and find things. But I will write that down. So hopefully, hopefully
I would definitely for next year try and
Yes.
get some of those other bits in, because I think, FEV1, I think unfortunately is a bit of a blunt tool these days.
Right.
And, imaging, yes, might not change with airway clearance, and you've got so many confounding factors, by the time you do one and the other, but it might give you some little bit more of a picture to work on.
No, thank you so much.
I think that's all for questions, so thank you very much,
Okay,
Kathy.
thank you guys.
While we're getting our next speaker ready, I can see like 3 chairs down at the front if anyone does want a seat. Just 3 of you, though.
All right, I'm excited to introduce our next speaker. We have Dr. Danielle Marie Getz, and she is a Pediatric Cystic Fibrosis Center Director and Co-CF Center Director at the CF Center of WNY in Buffalo, New York, and Clinical Associate Professor at the Jacobs School of Medicine at the University of Buffalo. She is co-director of the Therapeutic Development Network Center at UB. Dr. Getz is also physician leader for the CF Center of WNY's participation in the CF Foundation's Quality Improvement Learning Network, CFLN. She is also co-leader of the CFLN's Mental Health Eye Laboratory from 2023 to present. Most recently, Dr. Getz has been a member of the CFF Foundation's Committee for the Position Papers on the Evolving Care Model from August 2023 through present. She is a member of the New York State CF Center Consortium for CF newborn screenings. In addition to the CF care model, mental health, and NBS in CF, she is interested in exercise in CF as well as early CF care. And her talk is titled Airway Clearance After CFTR Modulators, What Do We Know and What Should We Seek to Know? Thank you, Danielle.
Sorry, that was so long. That was my thank you for the introduction, Janelle. So let me go to, how do I, let's see, I'm going to go to escape and I'm going to go. All right, so I feel like I was set up so well by Tom and Kathy, so thank you guys. You did a great job. So I just wanted to look at, there's so many things, like Tom said, things have been changing after modulators, and people really think they might not have to do airway clearance, and they might be exercising, and we're not going to focus on exercise. And I'm sorry I missed that session. I was presenting at another because it sounded like a great debate. But I just wanted to kind of see, and I kind of wanted to get your thoughts too, because where should we go from here? So this is our disclaimer, and I have no relationships to disclose, although I would like to disclose that I really feel great that I was included in this group of respiratory therapists and physiotherapists, so thank you. So I think first, my objectives, I just wanted to, I think we've already heard the benefits of airway clearance, and we all know that there's so many benefits over time, over history, and but now we're kind of balancing the benefits versus the burdens, and then we also want to think about, can we release some of these burdens without putting undue risk on the patients. And I'm pediatric, so I really want to know over time, is this going to influence people's lung function and progression of lung disease? So we're going to go over a little bit where we are at based on a survey that we did from our center through Community Voice, and kind of looking at the center's people who responded from the US and what they're doing now for airway clearance. And then kind of like where we should go from here. And as Tom mentioned, we may need more of a personalized approach. And when I was on the care model committee, that was one of the things that was kind of discussed, is that it may not be the same for everybody. And then I wanted to also get your input on further studies that we could do to help answer our questions. So we know that physiotherapy remains a key component in the treatment of CF. And I think we went over a little bit of this data, but right now there's no studies that have been powered to say that one form of airway clearance is superior to the other. But Kathy did a great job describing how active might have some improvements, but there have been no studies to say that FEV1 will be better in one versus the other. And then we know that airway clearance really does improve or maintain FEV1 over time and prevents decline. So this is so important. And we know that exercise capacity is an independent predictor of life expectancy. So maintaining airway clearance and maintaining that exercise capacity is really important. The number of treatments per day really differs in people with CF. So some people are doing 1 treatment a day, some people 2, and definitely people alter their treatments when they're sick. And it was actually interesting because we use the vest so much in the US, but in terms of one study that was done, people had worse outcomes in terms of pulmonary function and the number of pulmonary exacerbations on the vest. So I always think it's interesting that's, I feel, still the preferred method in the US. But we know that you need to concentrate on a method to ventilate behind obstructed lung units, and you need an expiratory airflow of more than 30 to 60 liters per minute to have a good airway clearance. So all the techniques Kathy described, you need to have that forceful maneuver that create those flows. So I thought this was a great review if you look from 2014 et al. About airway clearance. So right now we know we're in a period of time where we already have a lot of beliefs and practices about airway clearance, and then we have the advent of these highly effective CFTR modulators. So our beliefs and practices have been changing as we speak over the last several years, especially. So Kathy already kind of went over the history, but I just thought it was interesting, how many techniques have been developed over the years, starting in the 1940s. So it's been a long history. And this was from a review paper as well. And, going into the 90s and 2000s, there's different techniques, but really the goal has been the same for all. So right now, we kind of all agree that physiotherapy-related treatments, such as airway clearance and inhaled therapy, are considered the most burdensome by the CF community. Yet, conversely, they're also perceived as one of the most important of all treatments. So should we aim for best long-term physiological outcome at the cost of a continuing burden of treatment, or should we decrease the burden but at the potential cost of suboptimal long-term outcomes? So I think this is the question we're really all trying to answer. And they stated it well in this paper in 2022. So at the time of the pandemic, we were all trying to figure out, what we could do about airway clearance and what people were thinking about it, because in 2019, with the advent of ETI, we had that benefit where patients may have been healthier at the time. So at this time, we developed a survey at our center that was Community Voice is a wonderful, through the CF Foundation, is a wonderful group to work with. So they helped in the development and distribution of a survey that we created for providers and for people with CF. So we had, it was a simple survey monkey. We did a 16-item survey for the CF community and 13 items for CF providers. And we distributed this survey. At the time in 2021, when we did it, there were 1,600 people with CF in Community Voice. So this is a group where you can join if you're a person with CF or a family member, and you sign a disclaimer that the results will be shared with the community, whether or not the person participates in the survey. So it's kind of a good way to get, really the community's response to certain questions that we have. So we had 153 community members complete the survey. So that was only 9% of all the people in the Community Voice. So it's a pretty low percentage rate, but it was, I thought it was an okay number of participants. And then we had 192 providers, which were, I'll describe who they were. And then the survey is usually open for a 2-week period, and it's distributed through email and listservs for the providers. And then Community Voice has their own distribution list for people with CF and their families. So the objective of the survey was kind of to solicit feedback on the patients and the providers' views and practices. And we did ask about exercise, sorry, I have to mention a little bit, and airway clearance and what people are thinking in this post-CFTR modulator era. So out of the community responses, we had 74% were people with CF and 26% were parents. And then there were some other family members that had small numbers. Most of the, over half of the people were over 35 years old, and most of the people with CF were taking CFTR modulators, although 17% were not. And 65% said they were using airway clearance 2 times per day before modulators. And, but this number was higher in the parents who reported for their children as compared to the adults. And then, interestingly, 53% had discussed changing airway clearance with their care team after they started on a modulator. So this was the paper that we published last year, and in the answer to the question, since starting to take a CFTR modulator, which of the following airway clearance actions apply to you or your loved one? So actually only 13% said they had stopped all airway clearance. So it's maybe a little higher than we would expect, but it wasn't a very high number. And that was 16% of adults and then 3% of parents reporting for their children. And about half had not changed their airway clearance at all since starting a modulator. There were 30% who said they were doing fewer treatments. And then a lower number said they were doing airway clearance for a shorter period of time or a different type of airway clearance. And the answers were not exclusive, so they could respond to 2 categories as well. And then in terms of the care team, we had 47% of those who responded were physicians or advanced care practice providers, and 31% were respiratory or physiotherapists. There were some nurses and pharmacists as well. And over half had been in CF care for more than 10 years, so they probably had a lot of experience of how CF was before modulators. The care center size was evenly distributed among small to larger size centers. And this was the question to the care providers: for a patient on which of the following CFTR modulators have you decreased the airway clearance treatment plan? So for ivacaftor overall, it was about 17%. And for ETI, it was about half of providers had decreased. And in terms of none of the above, there were 48% of providers who reported that they had not changed the airway clearance at all at that point. So this was, again, 2021, so it was about 2 years after the start of the ETI. And then, what is the minimum length of time on modulator before you have considered decreasing airway clearance? Most, but not all providers, so around 89% reported considering decreasing airway clearance therapies. And then when we asked the amount of time, it was kind of spread equally among groups, but most people would agree that it would have to be 4 to 6 months or longer. And the option that providers would never consider decreasing airway clearance was not provided. And then again, for the providers, what criteria do you consider when deciding if it is appropriate to decrease the frequency of airway clearance for a patient on a modulator? Over half said lung function stability over time and number of exacerbations. And then patient family request was also one of the considerations. One of them was a patient exercising on a regular basis. And then 39% did answer this question that they have not discontinued airway or decreased airway clearance at that point in people on modulators. So that was kind of our study on what people were thinking at the time of, how frequently or should airway clearance be decreased. So then I was looking toward the burden of, we already kind of know about the burden, but these were a different study where they were looking at after 1 year being on ETI, did patients have less of a burden? So this was done in the UK. And they found that there was about a 15-minute decrease for each of the categories of treatments per day that they were doing less of because they were on ETI, so they didn't feel like they needed to do. So it was aerosol therapy was one category. So they got about 17 minutes for that. Time engaged in airway clearance was about 16 minutes less. And then time engaged in cleaning and disinfecting respiratory equipment was about 16 minutes less. So those are all categories that people felt, they decreased their time somewhat because they weren't doing them as much. So we know that there's other studies that have shown the burden may be reduced, but is reducing airway clearance actually safe? Because that's the question. So the Simplify study didn't look directly at airway clearance, but it looked at inhaled medicines, right? So they tested a non-inferiority hypothesis that the mean difference in percent predicted FEV1 from baseline between the arms that discontinued treatment versus those that continued treatment would not be less than 3% or negative 3%. So there wouldn't be a 3% change if you stopped your DNase or hypertonic saline. So the patients overall had to have, good lung function. So greater than 70% if they were less than 18 or greater than 60% if they were over 18. And then they also had to be good recorders that they were actually adhering to those treatments before they stopped them. So that makes sense. They could not be taking them and then just say they stopped them at that point. So the Simplify study showed that when they discontinued hypertonic saline or DNase, they did not have a drop in their lung function that was significant compared to those who stayed on them. So you can see that the lines on so they looked at FEV1, and there was no significant change among the groups. And then LCI, which is a little bit better marker of ability to clear nitrogen from your lungs. So if they're sicker, you can't clear the nitrogen as well. So this did not also significantly change. And they're showing the confidence intervals here for LCI and then FEV1. So basically, they concluded that people with CF who are clinically stable on ETI can safely discontinue DNase or hypertonic saline without any meaningful short-term effects. And remember that the study was only 6 weeks, but they are looking at longer-term data after this. And there's also the Quest study, which has completed enrollment, which was examining the beliefs and opinions of a subgroup of Simplify participants about treatment withdrawal research and perceived treatment burden. So again, trying to answer the question of coming off these therapies, is it a improvement in their burden, but not giving them too much risk? And then this I haven't seen the results of yet, but you guys might know it before me from UK, but CF Storm is a 52-week randomized registry-enabled open-label trial in the UK assessing change in respiratory function in people with CF at least 12 years of age. So they're randomized to continue or stop Dornase alpha, hypertonic saline, or both. So this is kind of a longer version of the Simplify study. So I think maybe those results will be published soon, but you guys can let me know. And then looking at lung function and pulmonary exacerbations in individuals who discontinue chronic daily respiratory therapies, there was the HERO study, and Cynthia Brown presented on this yesterday. So this was a 52-week prospective observational cohort study investigating the change in lung function among people with CF at least 12 years of age who changed their treatment regimens after starting ETI. And this study actually leveraged social media to facilitate enrollment and had a web-based application. So all the participants had to do was they could use, they didn't have to, we gave them a flyer and basically they could do it online. So it was kind of independent and it was based on their reports. But I had missed the session due to something else, but luckily I saw Cynthia Brown in the elevator today. She told me the results, which were mostly that they followed the patients over 12 months and 22% of patients stopped airway clearance. And these patients did not have a significant drop in their FEV1, and they did not have a significant increase in their exacerbations. So this was, I believe, people 12 and up, so it was adolescents and adults. So there is at least some data that over the 12-month period, the 22% who stopped the airway clearance did not have a change in their lung function or exacerbations. But I still am a skeptic because I think there are other measures like Tom mentioned about, if you have bronchiectasis and you have CT changes or MRI changes or whatever you're looking at, that's still going to be there. So, but this is the data we have so far, and these are the 3 studies. And kind of, this was a great review in Current Opinion in Pulmonary Medicine that was looking at the outcomes and the withdrawal therapies. But I always think it's interesting. They're talking about the inhaled therapies, but not so much about the airway clearance itself. But at least Hero was talking about the airway clearance. So, and then just turning to exercise just briefly, because we did ask about it in our survey, kind of as the comment that was given, exercise therapy is more easily accepted by any society, which helps to normalize the lives of CF patients rather than placing a psychological burden on them. I thought that was an interesting quote and a way to look at it. And with people living longer with CF, we know they're going to have to exercise because they need to maintain their bone health, mental health, and muscle strength, and exercise capacity, which we know is related to mortality, inversely related to mortality. So does exercise count as airway clearance? I was not at the debate. I was giving another talk. Otherwise, I would have loved to see. But I hear that both had good arguments, my friends told me. So, can exercise substitute with airway clearance? I was interested in this when we did the study of the survey. So there's not much data on it, but basically this review had shown that, exercise can increase the FEV1 when you add it to airway clearance. So I thought that was interesting. And then 5 studies compared exercise with traditional airway clearance, and then they couldn't do a meta-analysis because they had different forms of airway clearance they were using and different measures of lung function, so it wasn't too helpful. And then one study showed that mixed exercise improved FEV1 compared with active cycle breathing techniques. And then the 3 studies that compared exercise versus rest, I didn't think were as helpful because I thought, clearly exercise would be better, but that was what was available for the data we have right now. And then the only study out of those studies that were presented in the paper that really looked at more long-term exercise which was cycle ergometry, was during a 2-week hospitalization period where they found no significant difference between the interventions, which was exercise compared to traditional airway clearance. But that was just during a 2-week hospitalization period. But I put that in there because Frank Cerny was an exercise physiologist that worked in Buffalo, and he was kind of a cool guy. And so I put that in there because that was the study that was trying to look at a longer period of time. So there's a longitudinal relationship between physical activity and lung health. So this was a study which showed that the degree of lung function decline is actually better in people who exercise than people who don't. But they used habitual physical activity. So these were just like activities of daily life. And so people who had those, and the change was only from like 1.39%. It went down to 1.39% decline per year as compared to 1.9. So it doesn't seem significant, but those little percentage points are, add up over time. So that was kind of support for that. And then there was a consensus report about exercise as airway clearance in the UK, and they said that exercise, because when we're counseling people about exercise and airway clearance, sometimes it's like, we're like, oh, exercise is good, but it's like not clear how much to do. So it really has to be greater than 20 minutes duration with an intensity that elicits deep breathing. So the exercises that people, so these were mostly like respiratory physiologists and clinicians who felt that, you really had to get that huff cough in there was the bottom line I got out of this that you need those during exercise and in the recovery period, and you need deep breathing. So really, they are doing airway clearance as part of their exercise. So that's kind of interesting that, you do need the airway clearance. So I guess I agree. I'm glad we're in this session. So really also these professionals thought that we really need to do more intense exercise. So again, like standing around drinking coffee while your kids are exercising is not going to be that helpful. So this was just kind of an opinion with the experts. But is exercise part of the airway clearance plan? So in the survey we did, we found that 78% of clinicians out of the 192 respondents prescribed exercise as part of the airway clearance plan. And 68% believed exercise could partially replace airway clearance. And of these 68%, 36% had changed their opinion because of modulators. And then there's a session on should exercise replace traditional airway clearance after this as well. So what should we seek to know? I don't know that I've given a lot of answers here, but we have more questions than answers as always. So is it safe and acceptable for people with CF with mild to moderate lung disease, but stable clinical course on modulators to withdraw airway clearance treatments? How many and for how long? So this may be one of those areas, in my opinion, that's kind of like when we were on the care model paper. Sometimes these things have to calibrate over time. You have more periods where you may need more airway clearance. You may have periods where you need less airway clearance. And I think, like Tom said, where you're teaching the people to assess, how they feel and what they need at the time might be helpful. Also, I think the imaging and using other techniques to assess rather than lung function, like maybe we need to do LCI in more people to assess those subtle changes in lung function that aren't, like you said, aren't going to change with FEV1. You might need more subtle ways to detect changes, especially in children, because we really don't know the long-term effects of the modulators. And also in adults, if you have bronchiectasis, you still need airway clearance. So those are some of the thoughts we need to think about. And then the other question that's kind of related, but not directly airway clearance is it necessary to start mucolytics in young children without structural lung disease and on modulators? So this is a question I struggle with because it's recommended that all children start on mucolytics at age 6. But if they don't have significant lung disease and their lung function's normal, do we have to do this as a preventative measure? I still am, but that's a question we still have to answer through research. And then could people with CF use airway clearance for breakthrough symptoms only? Somebody had kind of asked Tom that question, and I was reflecting on my patients, a teenager who grew Pseudomonas later. And they came from another center a couple years ago, and despite me trying to get them, on their airway clearance, on their inhaled medicines, they never did. But when they were sick, they really needed it. So we were kind of in a conundrum, like, we need to get this going and fast, and you know how fast the medical system can work. So I think that breakthrough symptoms could be a time to use more airway clearance, so I think it's important that they have something available. And then can exercise replace part of the airway clearance in CF? I think so, and I think some physicians would agree, but I don't have a large sample size. So we might have to continue to study this. And how might we study this? I think the HERO study did some work to try to study it, so there might be more kind of real life studies that could help us answer these questions. So please, if you have any thoughts on any of these studies or potential interventions, I'd love to hear from you guys, and thanks for your attention.
Thank you, Danielle. You had 39% of patients who didn't want to reduce their airway clearance. Did you look at the age range? Was that more of an older generation who just didn't want to change, or was that a younger generation?
Because of our small sample size, I don't think we looked at it, but it is an interesting question. And actually, in preparation for this talk, I was hoping to repeat the survey because I wondered, now that it's been almost 5 years since ETI, would things have changed? But I just ran out of time. So if anyone thinks that it would be worth repeating, I wondered your thoughts on that. But I would like to look at different subgroups, because I think that does play into it. Like if you're an adult, you probably think differently than a child. Although more adults seemed willing to reduce than parents. So it's interesting.
For those patients who do stop airway clearance, what's your follow-up time? Like, how long do you leave it before you kind of come back to that question about restarting it, or whether it's still appropriate to stop?
In our own practice, we've not, certain patients have stopped it on their own. So I haven't really said stop all airway clearance to anyone. But so what we usually try to do, like Tom said, is compromise. So we're like, if you do one airway clearance and then you're, doing field hockey every day, maybe that's enough. So we've been trying to kind of just look at their lung function. And that's another thing we struggle with, because if patients are going to be coming to clinic less frequently, as the care model is changing, it'll be less assessment points. So I really try to keep a close eye. And because we have a smaller center, we're able to kind of like keep a close eye on the patients. But in bigger centers, I think it's hard too. So I think you have to think about like a 3 to 6 month period. You can't let them, I don't think you can loosen the reins that much if you're reducing things.
If there's no more questions, we'll let you off a bit easily, just in the interest of time. So
Perfect. Thank you so much. Oh, thank you.
All right. And finally, we have Lucy, our wonderful moderator / speaker, up next. Lucy Wadsworth is a clinical specialist physiotherapist at the Manchester Adult Cystic Fibrosis Centre in the UK. Lucy has worked in CF adult care for over 10 years and leads the cystic fibrosis and non-cystic fibrosis bronchiectasis inpatient physiotherapy team. Lucy has a special interest in airway clearance and non-invasive ventilation in adults with cystic fibrosis. Lucy's work is currently focused around hospital admissions post-HEMT, non-invasive ventilation in the era of ETI, and evaluating the change in ACT and CF exacerbations. And she has just been the most wonderful co-chair for this session. We've been working together since, oh goodness, has it been maybe March, April? And she's just always brought the energy and the organization, and she's coordinated putting together all of the Zoom calls across all our different time zones. So she's just fantastic. So welcome to the podium.
I'll give you a tip later. Just thought out. Okay, so just check, can everyone hear me okay? I'm quite quiet usually. Okay, so, I've gone already. So today I'm going to talk about the aging CF lung and its implications on airway clearance techniques. I have no disclosures. So first of all, my colleague, Janet, recently said to me, how old is old? So let's find out. So at the age of 36, I am old in the eyes of my 2-year-old. And Penny might actually be right, because at 36, my lungs are starting to age. It's been reported that FEV1 can peak at the age of 36, with an annual rate of decline after this of 20 mils per year, increasing to 40 mils per year in a general population after the age of 65. It's Monday. Let's move around. I could watch that all day, though. And we know aging is natural and inevitable, and a process that starts for us as soon as we're born. And we're an aging nation across the majority of countries, with age-associated respiratory conditions being the third leading cause of death over the age of 65. But when does that decline in physical and cognitive function start to impact patients with cystic fibrosis? And moving forward as clinicians in a CF aging world, how easy is it for us to separate CF symptoms away from aging symptoms? And when should we actually expect to see this? And we need to think about how aging is actually going to impact on the respiratory CF system. Many people will be familiar with the hallmarks of aging. It encompasses the biological processes that contribute to the aging process. and our bodies and cells will undergo constant insult throughout our lifetime. DNA damage due to exposure from environmental factors, mitochondrial dysfunction, decline due to the accumulation damage, leading to decreased energy production, protein damage, and inflammation. And it's this chronic inflammation, or its now trendy name of inflammaging, that we obviously find very relevant to a CF cohort that has significant implications that contribute to that aging process. Inflammation promotes cellular damage and dysfunction, leading to decline in function of organs and systems and accelerating that aging process. We know inflammation increases the risk of chronic diseases such as cardiovascular disease and cancer and neurodegenerative disease, but we know it also impacts on cognitive function and muscle and bone loss. So how are all these diseases going to impact our CF population? And they're things that we're definitely having to consider now. The SPRINT study by Lord is an observational study. It's been reported on recently in the Growing Older with CF report from this year, but it covers aging, looking at the effects of Kaftrio on inflammation. In this study, blood and sputum samples were collected pre-therapy and then again once participants were taking Kaftrio. And it showed that both lung and systemic inflammation persists even after receiving a CFTR modulator. So this ongoing inflammation may have implications for the long-term health and potentially interfere with that normal aging process. But aging in CF is looking different. We know it was once that pediatric disease. It's forever looking more promising and hopeful for especially newborn babies born with CF nowadays and those eligible for CFTR modulator. And this is Margaret. Margaret is our second oldest patient at Manchester. She was diagnosed as an adult, but she continues to work really hard at her CF to stay well and to age well. And we're really hopeful that more patients will be able to age well like Margaret as we approach this geriatric CF world. But if you ever meet Margaret, don't tell her I called her that. But for majority of us, our cohorts will still remain, our highest cohorts will still remain in sort of a higher 20 to 30-year-old population. So it's something that we're moving towards. This may be the 7th or 8th time you might have seen this slide today in this conference this week. So sorry to show you this slide one more time, but we know that patients are aging. And with that aging, they will pick up other comorbidities along the way. And so just thinking how we need to prepare for that. So today, ideally, I just want to try and speak to you about just aging lung and how that's relevant to a CF patient, what we're already observing, and then what is ahead of us, and then what this means for us as physiotherapists, physical therapists, respiratory therapists, and how we apply and keep promoting that into practice. So age-associated respiratory conditions such as COPD and IPF and asthma are the third leading cause of death in a general population over the age of 65. And just as we see natural changes occur on the outside of our body, natural changes will occur to lungs as we get older as well. The lungs will undergo a series of transformation over time, and these changes will affect their structure, their function, and overall efficiency. And perhaps one of the most important aspects of aging lungs is the decline in the immune system's ability to respond to infections, making adults more susceptible to respiratory infections and especially viral infections. And you might already be seeing this with your older adult cohort at the moment when they tell you that it takes them longer to get over an exacerbation, or the fact that our respiratory wards are full of geriatric patients with pneumonia struggling to ventilate when faced with increasing metabolic and respiratory demands. And so again, we ask what impacts this will have on our geriatric CF patients and their lungs. The hallmarks of aging were applied here to COPD, lung cancer, and IPF. It just highlights how each hallmark differs in the extent dependent on disease. But we can see here how in COPD, cellular senescence plays a role with aging lung cells becoming dysfunctional and contributing to that inflammation and tissue damage. Genomic instability is particularly relevant in lung cancer, and in IPF, stem cell exhaustion and cellular senescence contribute to the aging process, all leading to that excessive fibrosis and lung damage. But how easy is it actually to see aging on a CF chest X-ray? These are all CF patients. And you can probably tell me who has the most severe disease fairly easily, but who has the oldest lungs here? And this is where I don't know whether to just leave you on a cliffhanger and never tell you. But it's the one on the right. And so although chest x-rays may be difficult to identify aging changes, there will be other signs. And what I thought was just interesting is that this list of physiological changes seen in an aging lung could easily be applied to patients with cystic fibrosis now. There's this chest shape changes, which we all know, that classic hunched over position, forward leaning position, promoting that increase in kyphosis. And with this curvature, it causing a decreased space between ribs and creating a smaller chest cavity. Mucociliary dysfunction has been reported to be delayed in an over 40-year-old population. It was again resulting in the accumulation of secretions and increased risk of infections. There's lung function decline, there's sleep changes, there's muscle weakness, with overall muscle function in the body reducing by 2% annually as we age. So it has the ability to impact on our inspiratory and expiratory muscle strength and our cough effort. And together, these changes can lead to increased susceptibility of mucus and retention and may contribute to recurrent infections, atelectasis, and progressive airway obstruction. And so all changes that occur naturally but can progress quicker with CF disease in the background. And so when we compare severe lungs to aging lungs, there are very similar comparisons, but with more significant dysfunction and damage in lungs that are affected by acute or chronic disease and inflammation. But now we need to think about the addition of lifestyle, environmental changes, smoking, long-term medication use, and a lifetime of radiation to our CF cohort, as all these will influence the extent and rate of lung aging. And so at what age do we apply aging lung to our patients with cystic fibrosis? And perhaps they actually have already just interlinked now. So move on just to our second question of how this is just relevant to the CF patient, because we know firsthand that life expectancy is increasing. And I just thought it'd just be interesting just to go back to some data from 20 years ago, where really you were lucky to see your 40th birthday. And you can see here as well, the highest age profile on this graph is 35 years and plus. But you compare that to now in 2003, we have all these increasing aging profiles with, again, the population just increasing. And so now we have our final age profile here of 68 plus. And we know why patients are growing older. The advances in CF treatment have been phenomenal, and even just a very small amount of time. And especially now we are in the era of CFTR modulator therapy. We learned a lot from the ivacaftor data from the initiation and the 5-year follow-up period, but what do we currently know about the long-term ETI studies? We're 4 years on from ETI being available to the majority of us, and long-term studies are slowly becoming more available with some really helpful data, but information is only as quick as just time goes by. But what we do know is ETI is well tolerated. We probably all have 1 or 2 patients who have had a bit of a bumpy ride with it and some very known adverse effects with it as well. But overall, we are observing a reduction in hospital admissions and exacerbations and increases in weight and decreased referrals to transplant. And here, Flume, Bauer, and Danes have all published on the long-term safety and effectiveness of ETI, with study length progressively getting older, and all these studies with very similar outcomes, but we hope over the next 1 to 2 years, we'll actually see that long-term 5-year data from ETI. So at question 3, what are we already observing and what is ahead of us? What is a CF aging population going to present us with? And this is an extensive list that I had to reduce, and I haven't even touched on the psychosocial side of it as well. But CF, as we've heard much throughout this conference, and especially today, will continue to have bronchiectasis. So we still need to engage patients with airway clearance, and especially those ones who do claim to be a non-producer, because we can show them that mucus and bronchiectasis do still remain. However, if we apply ETI and aging to this population, are our patients, as Tom also alluded to, so we're on the UK thoughts pattern here, that we actually might see our patients presenting in a more non-cystic fibrosis pattern. And this means because medications in the elderly population do work differently. So we actually might start seeing some intolerances to our well-known CF inhaled therapies. I've touched on age-associated diseases such as asthma and COPD. We at Manchester already have a collection of CF patients with asthma diagnosis as well, but are we set to see an increase in prevalence and other respiratory conditions within our CF cohort? And especially a change of symptoms and patterns of symptoms and radiology changes as well. We're also a heavier nation, us and cystic fibrosis patients, and so it just demonstrates how far we've come. But with increase in obesity, an increased risk of cardiovascular disease, risk of stroke, and sleep apnea also come along with it. Obesity can impact on lung function and increase breathlessness and increase stress on the joints, impairing mobility. Aging brings about less activity, less movement, boredom, isolation. And so how do we keep this population moving? Sarcopenia is age-related atrophy of muscle fibers, but again, what do we know about it in a CF cohort and the ability to impact on respiratory muscle strength? Menopause, although a very natural phase, hopefully a phase that many CF women thought they'd never have to encounter, and how wrong they were, it's here now. But as estrogen levels decrease, risk of exacerbation increases, with the potential to increase respiratory symptoms and impact on sputum viscosity. And so we just go back to the question from the start of this presentation, is it just CF or am I getting older? And the answer is it is probably both. CF symptoms will be linked, and us and patients need to learn how to manage these both, CF and aging. We need to know how to adapt to the changes ahead of us, as unfortunately, as these guys get older, more comorbidities and more alternative diagnosis will start creeping up on them. And there's many reports available now and standards, including and focusing on aging in CF in a preempt to prepare us all for the future. But it's a future that you could actually just say is already here, and we're already dealing with it in very small volumes or maybe slightly unconsciously. And so all these papers provide a really useful insight into what we think is ahead of us, discussing how aging in pulmonary disease will likely mean increase in severity of disease, multi-drug resistance infections, higher pneumothoraces, higher prevalence of hemoptysis, and all associated with reduced survival in an older CF population. But what does this mean for us? I just thought I'd have a look a little bit closer to home. So this is some of our Manchester physio data. We at Manchester have 134 patients who are over the age of 40. And I had 121 with some registry data just to have a look at. 49 were females, and we had 9 patients with cystic fibrosis who were over the age of 65, with our oldest being 84. And many of the patients were on a modulator therapy. We had 7% who reported urinary incontinence or a postural anomaly, although many of those patients were known to our musculoskeletal team or had osteopenia or osteoporosis in their problem lists. But from an airway clearance physio point of view, we had 35% of this population who said that they were doing no airway clearance, with only half having a secondary airway clearance if they needed it. And so I just thought it was just interesting data. I didn't really know what it really meant at this moment, but it made me just sort of think this is probably an area of our service that we should probably just assess further and make sure that we're actually promoting patient education and understanding of aging pulmonary disease in this cohort, ensuring patients have got the right tools for the job as their symptoms change and progress. But should we be keeping a bit of a closer eye on this cohort? Well, the answer is obviously yes. Following, obviously, the debate on Thursday, airway clearance is here to stay. Sorry, Lisa. But every patient from young to old now needs to have a form of airway clearance that promotes sputum movement and expectoration, as respiratory failure still for CF patients remains the primary reason of death. And the population is growing and living longer. And as this vision from the CF Foundation shows, there will still be a larger cohort where continued care is needed. So although patients feel like they may not need us now, they do. But with CF patients living longer, the combination of these aging changes will create unique challenges when implementing airway clearance. The primary reason for airway clearance won't change. We'll still need to move sputum from airways. But techniques that rely on high expiratory flows, such as coughing and forced expiration, now might be less effective in this aging cohort. A weaker cough effort will obviously make it harder to clear secretions, but alongside structural airway changes and mucociliary impairment, again, we'll obviously have an increase of secretion retention. But with chest wall changes, will impact on lung function, will impact on their capacity, but also might impact on the ability to complete a very effective thoracic expansions and targeted sort of lung volumes as well as they kind of once did. Lower immunity can increase exacerbations and increase need for airway clearance as well. But with that impacts on fatigue and energy expenditure and motivation in this older population. But aging to the body and mind will also impact on airway clearance in other ways. We might be faced with cognitive impairment or dementia, so this might lead patients to forget to do their airway clearance now, forget techniques, or forget how to problem solve it. Frailty can lead to quicker exhaustion and might reduce hand grip strength, so hand grip strength of holding adjuncts. Reduced hearing, it might just be another excuse for why they're not doing it, but they might not actually be able to hear us anymore, or hear the instructions, or hear the techniques and education. Reduced bone density may increase rib fractures, especially from coughing. Muscle performance, exercise tolerance means no longer we can maybe use positional airway clearance as easily. We may be more symptomatic in sort of certain supine positions, but we also may not be able to solely rely on exercise to support their airway clearance as well. And so given these challenges, and I'm sure there'll be many, many other unknowns ahead of us, how do we apply this to practice and continue to promote airway clearance in this cohort? And I think really here is education is key. I've recently found a quote that I quite liked, but they said, education is what survives when what has been learned has been forgotten. We just need to keep making sure our patients are educated on the importance of doing doing airway clearance, because at the end of the day, they still have respiratory disease. We need to make sure that airway clearance is still personalised to the patient's physiology, their age, their lifestyle, and their physical capability, and have reassessment dates in mind because they're aging quickly, and with that, symptoms will happen even quicker. And since when patients transition from pediatrics into adult care, we often promote them to be independent and self-manage. But with aging, we often revert back to almost being a baby again, where you become more dependent on people. You start to slow down a little bit as well. So we need to make sure we're involving spouses and carers, or maybe children for some of them as well, to help support them as they get older. PEP devices are have been particularly beneficial in an older generation, just by enhancing expiratory flow, but we just need to keep an eye on that cough and huff effort and making sure that's not changing. You've seen from our Manchester data, we have a large proportion of this older generation who actually even aren't doing airway clearance. So let's just make sure that the patients have the right tools for the job. This might include multiple techniques. Something's got to be better than nothing, and whether they pick up one or another. But we need to continue to promote an active lifestyle just to prevent them from doing too prolonged sitting, but again, something that is suitable to their capability. We need to think about fatigue management and energy expenditure. Sometimes just the thought of doing airway clearance is just exhausting. So shorter, gentler cycles may prevent excessive strain and fatigue. And passive treatments, I guess for here in the UK, in the US, you probably just need to think about the vest a little bit more and on bone density, but actually some passive treatments actually might be more beneficial to this older generation, and especially in terms of their energy. And so airway clearance in cystic fibrosis is challenging already, but add in age into this and other comorbidities, we may be in for a slightly sort of tricky time ahead. But with the appropriate modifications and individualized treatment plans and approaches, we can ensure treatments are more effective and sustained. And finally, I just have 2 case studies just to share, just to demonstrate aging and comorbidities that we're already facing. Both are ward management, because that's where I work. Oh, I'll go forward. But first of all is Terry. Terry is male, he's 73, he's on Kaftrio. He's got severe lung function. We've seen him 3 times already on the ward this year. A home oxygen user, got bone health, and long-term systemic steroid user. but you could really describe Terry as a very typical old man. Terry has actually been an old man with us for quite a while, and often you don't see his age, but when he's on the ward, he definitely becomes more frail in his appearance. He can be very grumpy, he can be very stubborn, he doesn't like change, which can make his physiotherapy management very difficult. He very much likes a set time of treatment. If the morning hasn't gone to plan, if he hasn't got right out on the right side of the bed, it really impacts on his mood. He doesn't like to be rushed. He only likes to be seen by us once a day, so we have one chance to go. Often his heart failure, his lower leg edema impacts on his rehab side and his walking then ability. And by the time you plan to finally see him, you can go to his room and you'll find him asleep. And you definitely don't poke the bear. But just what I wanted to highlight with Terry is his severe CF management, but just alongside his other comorbidities and his aging. He is very difficult to fully optimize at the age of 73, but it's definitely not for a lack of trying. But actually the best management of Terry is his wife. She has been pivotal. It's true. But she's been pivotal to his management, his NEBs, his appointments, his mobility, his falls risk. She is probably the reason he is still alive. And so any changes that we do, any promotion that we need, she is there to support us. And finally is Sarah. Sarah is 31 years old. She was only diagnosed last year, but already has quite severe lung function. And we've seen her 5 times already on the ward over the last year for a mixture of pulmonary exacerbations and pancreatitis. But Sarah actually had a stroke in her early 20s with ongoing right-sided upper limb and lower limb weakness. But she also has a very poor cough effort and a very low inspiratory flows. When we first measured her peak cough effort, it was only ranging from 60 to 120 mils. We tried efforts with AD and with PEP and with oscillatory PEP, but it was all kind of non-existent and not enough to generate any sort of sputum movement or enough flow. So with Sarah, we've actually introduced a cough assist with her to sort of support her airway clearance. And although she is a young CF patient, she has a comorbidity that we will likely see more of. And here we're using perhaps a non-routine CF, a non-routine adjunct, but this has been helpful to support her management. But as she ages, her stroke symptoms aren't getting better and will continue to age with her. So again, we're just learning how to coexist with CF, aging, and comorbidities. And so in summary, we probably just need to start thinking about aging for all of our patients now. And like I said previously, we probably are, but just a bit unconsciously. The promotion and education of airway clearance in this current older population is vital. They are more at risk. They never plan to do airway clearance for this long in their lifetime, and there's no retirement from it either. We need to think about tailoring airway clearance to the individual and adapt their physiotherapy and their airway clearance to them and their age. We can all help patients to age well, but aging and CF are definitely going to need to be interlinked, and we need to think a bit more broadly. And I think what's mainly important is we need to work together through this experience and ensure that we are sharing our experiences with this older generation as they continue to age. Just like to thank our team. You'd never be here without them, but especially for the ones here in the audience who are starred, and happy to take any questions.
I just had a quick question. So your cohort where you had, I think you said 10 that are over the age of 65?
Yeah, roughly.
Now, are all of them on ETI therapy?
Maybe 1 or 2 who aren't, and I can't remember now for why not. It may be adverse effects or not eligible, but the majority of them are.
Wow, that's fantastic.
Yeah. And maybe just to highlight, so the majority of our older population, probably more were later adult diagnosis as well, maybe again besides 1 or 2. This is pulling off memories.
Very interesting.
I'm still dealing with jet lag.
Aren't we all?
Yeah. Gemma?
Thanks, Lisa. That was a brilliant talk and really highlighting the problems that we're seeing at our centre as well, because we've got quite a lot of older people as well. And I think, the facts that you put about kind of people not managing, and, we had a lady who lost 2 E-flows because her carers put them under her bed,
Yeah.
and she couldn't get under her bed anymore. So she lived in one room, and she lost 2 e-flows, and all of us were like, how on earth do you do this? And then, yeah, exactly. It's like, well, they have to be there. And so, those kind of things that you just don't think about are really true. And this isn't really a question to be answered. It's more of a question to kind of throw out, I think, in the sense of, we hear quite a lot about when do things start, cancers start earlier in CF. And I just wonder whether those aging lungs are starting earlier as well. So, it might be that actually we need to think about that brilliant slide you had of all those problems, in the 30s rather than in the 60s. And I guess it's just having that in our minds as well as there's probably, I don't know how they do a study on it, but just, always having it in our minds. So, thank you for bringing it up.
Yeah, no, I agree. I think unconsciously it's probably in our minds, but I don't think we're necessarily thinking about it as age. And I think we still see this population as very young, but their CF will definitely progress their aging as well. So although they might not be classically old, they probably are. And like I alluded to my very first slide, I'm old apparently. So yeah, and I've worked in CF now for like 10 years, but that was then when I was like 25, 26, but I've aged 10 years and so have all those patients with me as well. So we're aging alongside all these patients now. And we need to just kind of just not forget that.
Okay, one more question, and then that'll be our time.
Make it a good one.
No pressure. Hi, I'm Megan. I'm from the University of Chicago.
Hi.
And I was just curious with your discussion of obviously everyone's getting older. Are you specifically looking at any frailty measures? We know that our patients have lower bone density and muscle weakness and things like that. So, specific hand grip strength is one of the ones that comes up, but any other questionnaires or
Yeah, I mean, we're lucky at Manchester. We have an occupational therapist, or 2 now, should I say. And I guess they've taken a very much active side in the frailty, but it's definitely, over the last couple of years, something we are 100% looking at more at, because it's here and it's coming here. And like I said, we've got a population who are over 40, and they are some of them are frail as well. And actually, to be fair, even some of the ones who are just more severe lung disease in their early 20s, early 30s, frailty is coming in and it's here. And yes, we are.
So are you classifying people as pre-frail and frail yet and providing any other different interventions?
I'm not too sure. I'm not necessarily directly involved with it at the moment as well, but there are patients who are having sort of screening tools, more specific sort of patients who are being identified for frailty. But I'm not sure if we've sort of honed in on the whole population yet to identify specifically that cohort.
Okay. Thank you
Thank
so
you very
much.
much.
That's great talk.
Thanks.